Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Chad Lorenz, a PGY3 anesthesia resident at the University of Saskatchewan in Saskatoon, discusses current perioperative brain health recommendations. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So this talk was titled Perioperative Brain Health Recommendations from ASA and the European Society of Anesthesiology. So we'll compare and contrast their two recent publications, which are both recommendations from a task force. They did it in a bit different ways, but we'll get into that. So just to preview the discussion on the objectives. So 3 objectives. First, I've already talked, we'll compare and contrast those 2 articles. And then the next is we'll kind of review or go over some major preoperative risk factors. Most of this will probably be review. I don't think anything's too new or exciting, but it's still hopefully maybe going to be helpful for rapid risk stratification. And then the third will be reviewing the state of evidence for 3 pharmacologic agents, which have a bit of controversy or I guess inconsistent evidence for and against. So that's midazolam, dexmedetomidine, and ketamine. And I'll just say, just as a preview to this talk, I think overall in the research, when we will go into these 2 articles, they have differences. Overall, though, you can tell that the evidence that they have reviewed is very much disappointing to them in terms of how heterogeneous the studies are, making it very difficult to do meta-analyses on and making it difficult to give specific recommendations for something like dexmedetomidine or something like ketamine, because of how variable the findings are, both from the side of the study population heterogeneity and the surgical population, as well as how many of the studies have measured postoperative delirium in ways that weren't validated, or they measured them in too short of an interval after surgery, so only 2 days after surgery. And we'll talk about ketamine specifically having evidence or a lack of evidence for its benefit in delirium because of many of the studies only researching ketamine for the first 48 hours after surgery, and therefore having a high rate of delirium, whereas the effects, there may be more beneficial effects after that 48-hour period. So let's get into it. So just to begin, the nomenclature update was 2018. There was a aim to align the terms with DSM-5. So specifically, postoperative delirium is the acute event occurring after surgery within 7 days or prior to hospital discharge, whichever comes first. And then in the 7 to 30 day timeline, we call it delayed neurocognitive recovery. And then between 30 days and 1 year, it's the term is postoperative neurocognitive disorder, which can be classified as mild or major, just like with neurocognitive disorder in general that's not related to surgery. So 30 days to 1 year is postoperative neurocognitive disorder. And then after 1 year, it's just neurocognitive disorder. And so it doesn't have the postoperative specifier after 1 year. Just to quickly talk about the motor subtypes, so hypoactive, hyperactive, and mixed. And then the etiologies, I think it's worth pointing out there's multiple ways of specifying delirium in general, and then post-operative delirium or delayed neurocognitive recovery or post-operative neurocognitive dysfunction all fall under the category of delirium due to multiple etiologies. So first of all, the first article of the two, the 2025 ASA Practice Advisory, this was a systematic review and meta-analysis done by a task force which consisted of anesthesiologists with expertise in caring for older adults, and then a geriatrician, a geriatric surgeon, and statisticians. The task force developed key questions. We'll see that on the next slide. They defined a PICO for each question, so a population, an intervention, a comparison, and an outcome. And then they looked at the literature, and they were specifically looking at older adults over 65 years of age undergoing inpatient surgeries. And they looked at both randomized controlled trials and then other study designs. And then they evaluated the evidence using the GRADE framework. So they had 5 key questions, and they made recommendations on the first 4 key questions, and we'll go over those 4 recommendations. I won't read them off the slides because we're going to talk about all 4, and they're based just directly off of the key questions. And then the second article is the European Journal of Anesthesiology. This came out 2 years ago. The ASA's article came out 1 year ago, so they're relatively recent. This article was an update from their prior consensus-based guidelines on postoperative delirium. So they did an update because of the massive amount of research that had been undertaken after their first guidelines came out in 2018. So the literature search was between 2015 and 2022. And just to point out, they really went into the role of surgery-induced inflammation in the basic science section of this article. And then they highlighted that there's a lot of basic science research which doesn't get mentioned in recommendations now, but they're anticipating some of the research going into biomarkers and other things. They're anticipating that these will inform recommendations in future updates. And so they had very strict criteria for their literature review, and they essentially did the same as the ASA. They looked at the risk of bias overall in each of their questions, and then graded the strength of the evidence using a systematic framework. So a comparison between the two, I think the biggest thing to mention is that the ASA task force had a overall group that looked at all the evidence together, whereas the EJA split up their overview on postoperative or pericognitive neurocognitive disorders. They split this whole literature review of 1,700 studies into 6 groups. So the first was basic science. The second was risk factors. The third was preventative measures 1, which was pharmacologic agents. The fourth group was preventative measures 2, which was non-pharmacological interventions. The fifth was neuromonitoring and EEG monitoring. And then the sixth was treatment of postoperative delirium after surgery. They do not have recommendations from the first group. As I mentioned, this was all the basic science component, but they're very excited about the role of some of the biomarkers that they're hoping to have translated into clinical research in the coming years. So they have recommendations for all of the other 5 of the 6 categories in this EJA article. I think it's worth mentioning, so we'll get into the EEG monitoring. I think there's some important things to cover in that, but the ASA article they explicitly avoided talking about depth of anesthesia because they said the research was so inconsistent. So we're going to divide the talk up into pre-op, intra-op, and post-op. Spend the bulk of the time in pre-op and intra-op, and then there'll be a few slides at the end regarding post-operative treatment. using pharmacologic agents, and that's dealt with just the European Society of Anesthesiologists recommendations, because their article was hoping to inform ICU practice as well, but it's applicable for anesthesia. Excuse me. So just to begin, the epidemiology of perioperative neurocognitive disorders. A recent meta-analysis showed the rate of or incidence of postoperative delirium is actually probably not surprising, but it's quite high in emergency surgery, so 32%, and versus 19% of the time in elective surgeries. We have a reported rate of 10 to 50% of postoperative delirium, depending on the surgery type or emergency surgery. And it's just worth noting that as a factor for postoperative delirium, we have many. We're not going to get into all of them, but the odds ratio of postoperative delirium increases by 11% per hour of surgery, reflecting the critical role of physiologic stress during surgery. We don't probably need to spend too much time on why this subject matters, but it's just worth mentioning that postoperative delirium and neurocognitive disorders have an association with worse outcomes in terms of mortality, functional outcomes, higher rates of institutionalization after surgery, and a higher dementia risk. So the first recommendation of 4 from the ASA article was that there is a recommendation to have expanded evaluations for frailty, cognitive impairment, physical function, nutrition, and psychosocial issues in patients older than 65 years of age. So their focus that they suggest is to really focus on frailty, mood and anxiety issues, cognitive status, malnutrition risk, baseline function, and polypharmacy. It's worth noting that their strength of the evidence was considered low, and the recommendation is conditional, and therefore that means that their task force believed that most clinicians would choose this, but not all clinicians would choose to expand their preoperative evaluation of older patients over 65 undergoing inpatient surgery. The EJA has quite a similar recommendation, but they highlight 4 critical risk factors for postoperative delirium, which is older age. So over 85 has a very high rate of postoperative delirium. Their risk factor number 2 is an ASA 3 or greater. And then the Charlson Comorbidity Index greater than 2. And then the last was a MMSE score of less than 25. And this was a strong recommendation by EJA with moderate quality evidence. This essentially coincided with a very large meta-analysis that was related to this study and was published in BJA. This was a study that looked at over 169 studies and looked at over 500 risk factors, and they came out the exact same set of 4 critical risk factors. So the ASA, the Charlson Comorbidity Index, age, and then an MMSE score less than 25. They had a few other very strong recommendations in terms of risk factors, which we'll touch on here. So a hemoglobin less than 111 was considered to be a risk factor, as well as blood transfusion intraoperatively, cardiac surgery, hip fracture surgery, hypotension during surgery, and then the length of the surgery. And just a note about this expanded preoperative screening, it does have evidence for reducing the rate of postoperative delirium, and it's odds ratio of 0.77. This was from the ASA article from their meta-analysis. But aside from reducing postoperative delirium, it has no impact on other secondary outcomes such as physical function for the patient, length of hospitalization, ICU, mortality, et cetera. So the preoperative screening expansion can impact postoperative delirium, but not other outcomes. And the EJA essentially goes into just more detail on what this expanded screening is all about. And so they recommend the preoperative consultation being a multidisciplinary, multi-component preoperative consult, and they call them bundles. And the focus is on frailty and older adults with low functional reserve. And they go into this in the paper, the body of the paper, talking about single interventions have some evidence like correcting for anemia, hydration status, nutritional deficits, cognition, but the multi-component bundle is critical. So using a team-based approach, utilizing geriatricians, rehabilitation specialists, and a surgical team, and having good communication between all members of the team, and meeting with the patient and their families to go over their risk factors, and then going through things like polypharmacy, functional status, et cetera, and then correcting for them in a whole team-based approach. And so they have this as a specific recommendation saying that the results of the screening for postoperative delirium risk factors should be shared amongst the care team, and then have the preventative strategies discussed as a team. And this was a strong recommendation from EJA. Just talking about cognitive status, with a history of delirium, the odds ratio is 4 for a patient to have another incident of postoperative delirium. And just to talk about like frailty, we're going to talk about quickly patients with frailty or significant decline in their functional status or their ability to carry out activities of daily living has a very strong relationship with postoperative delirium. A couple other things worth mentioning is polypharmacy is well known to have a relationship with delirium, as well as activity, like I said, substance use, and a low BMI. In terms of recommendations from the two papers, they do not have any recommendation. They actually specifically say they do not suggest using biomarkers to identify patients as at risk of postoperative delirium. So take that out of our minds, I suppose. And then I'll just talk about frailty because it's so strongly associated with postoperative delirium. We hear about the Edmonton frailty scores. There's many different frailty scores. I went into a little bit of a search in terms of what might be the best one, and it turns out there's some evidence in terms of the Edmonton frailty score having a stronger relationship with postoperative delirium, but it is proprietary. You can't get it on MD Calc. And when I looked into it, it looked more like it was because of the fact that the studies that were investigating the relationship between the various scores were not actually, when they did a meta-analysis, they just the clinical frailty score, which I have on this slide here, just wasn't used. And so it was more just that there was a lack of there's inconsistency and bias in the research. So I'm just putting out here the clinical frailty score as an option to rapidly risk stratify a patient. It's 2 minutes, 1 to 2 minutes in terms of coming out with a number, versus the Edmonton frailty score is 5 to 10 minutes. It's much more structured, and you use the timed get up and go test and other things. And so this is just a rapid quick screen of the patient on a scale from 1 to 9. 9 is terminally ill, severely frail. 1 is very fit. 5 is right in the middle, where you need a little bit of help with your IADLs, including finances and heavy housework. And then you ask the patient specifically, like when they're at their baseline, their average baseline. If they're sick today, feeling really off, going for surgery, that's not what the score is based off of. So I find that this clinical frailty score is quite useful because of how fast it is. And when I looked into the research, it did look like it has a very significant statistically strong relationship with mortality. And I just don't think it's been used as much for research on delirium, but I think it's still quite useful. And then just talking, I think I'll skip this slide just for the interest of time in terms of the association. We just know that frailty is very strongly associated with postoperative delirium. The UK guidelines have a quick screen of 4 things for a high-risk patient. That's number 1, age over 65, number 2, cognitive dysfunction, number 3, a current hip fracture, and then 4, severe illness. So that's a nice, quick, rapid screen. And then just a note on alternative cognitive screening tools besides the MMSE. There's the MoCA and the MiniCog would be the most common. We won't get into those scoring. And then just a quick recap of the Charlson Comorbidity Index. It's a score out of 37. And these recommendations, both the ASA and the EJA, state that if you have a score of 3 or more, you are at a high risk of postoperative delirium. So it includes myocardial, a history of a current history of myocardial infarction, CHF, dementia. Those are actually all scored 1. Mild liver disease, ulcer disease, connective tissue disease, pulmonary disease, diabetes without complications. Those are all 1. And then hemiplegia, moderate or severe renal disease, end organ damage, diabetes, and tumor without metastases are scored as a 2. And then severe liver disease is a 3. And then a metastatic solid tumor scores a 6. MMSE is a quick screen that we all know that you can get easily on your phone. So a score of less than 25 is considered to have a significant relationship with postoperative delirium. And so that completes our preoperative section. Now we'll get into the intraoperative period. The ASA did not have a recommendation regarding non-pharmacologic interventions, which I found interesting. It was just the EJA, but they really hammered home the point that there is strong evidence for multi-component preventative interventions having a role in reducing the risk of postoperative delirium. And so that was a strong recommendation. And in this, in the vein of the multi-component preventative intervention, it actually encompasses the preoperative and intraoperative period. And so they had a lot of studies that did a lot of things, but we'll just touch on one just to get a taste of what these multi-component bundles are. And I just want to point out, this will be re-emphasized in my summary, but the evidence is actually much stronger for the non-pharmacologic multi-component bundles in preventing delirium compared to pharmacologic strategies. So this is a busy slide, but it's just to point out that a study that had a relative risk of around 0.25. It was a randomized controlled trial published in JAMA, and specifically postoperative delirium. And it was just one of these non-pharmacologic bundles that did universal protocols. So they oriented the patient prior to surgery and showed them around the ICU. They did therapeutic activities, and then they had stressing, early mobilization and nutrition, and early catheter removal in the patient. And then they did targeted protocols in addition to these universal protocols based on screening by nurses or paid volunteers or family members. And they were looking at things like pain management, sleep enhancement, nutrition assistance, fluid repletion, and then vision and hearing enhancement, as well as ensuring there was no episodes of hypoxia, and then doing all sorts of things to prevent catheter-associated UTIs, and then really looking at ensuring that there was no polypharmacy unnecessarily post-operatively. And so it was both a preoperative and post-operative multi-component prevention bundle. And this, like I said, the risk reduction in this study alone was like over 80% of the rate of postoperative delirium. And the number of patients, I think I can't say, but it was a relatively large amount of patients. And I think it's just nice to touch on all the different, quite a resource intensive strategy, but dramatically reduced the rate of delirium. And yeah, this just talks about their orientation protocol involved like talking with the patient and letting them know where they are 3 times a day. And they had various cognitive stimulating activities and early mobilization. And that was universal in this protocol. And then they targeted anyone who had pain problems, that they had non-pharmacologic strategies, including relaxation techniques, massages, etc. And then they really focused on sleep with anyone that had disrupted sleep. So recommendation 4.3 was a strong recommendation that was a non-pharmacologic multi-component intervention for all patients at risk of postoperative delirium. And the bottom line is that despite different types of interventions and bundles, that the evidence is there that non-pharmacologic strategies work. They're very resource intensive, and I think there's a reason why it's not done universally, and I'll just leave it at that. Now, just a refresh of intraoperative factors that have a relationship with postoperative delirium: the duration of the surgery, as I mentioned, hypoxemia, difficult hemodynamics with hypotension, blood transfusion, and then specific surgery, specifically hip fractures and cardiac surgeries. It remains, evidence is not clear on cerebral oxygenation parameters being associated clearly with postoperative delirium. And that caused a little bit of a controversy in the discussion after the EJA articles. There were some angry letters to the journal that cerebral oxygenation was not mentioned as one of the recommendations. So to get back on track, recommendation number 2 out of 4 from the ASA was that GA and neuraxial are both fine using a decision-making process. This is not news to anyone. Essentially, there's no evidence that neuraxial or regional anesthesia has any impact on postoperative delirium. We won't belabor the point. EJA had a more broad recommendation. It was just specifically, they did not recommend any specific type of anesthetic or type of surgery in terms of open versus laparoscopic. They said that the quality of evidence overall was low because they only had one randomized controlled trial for the open versus laparoscopic. They just had a bit more broad statement here, but they just, again, it's just reiterating the point: neuraxial versus GA has no impact. Recommendation number 3 was total intravenous anesthesia versus volatile anesthesia. The recommendation number 3, meaning from the ASA article, and so there is no recommendation for choosing one over the other. You can do TIVA or volatile anesthetic with some confidence that you're not impacting the patient's rate of delirium. However, what's interesting is that they didn't really mention that there is short-term benefit in terms of recovery room benefit, with well-known benefit of TIVA with postoperative nausea, vomiting, and patient satisfaction scores. I just want to mention that. But overall, in terms of postoperative delirium, there's no evidence suggesting that TIVA or volatile anesthetic has any difference. And this is just summarizing the evidence that they looked at, and there was none. There's no difference between TIVA versus volatile anesthetic. This basically was just confirmed with the EJA recommendation. And I will now move into talking about dexmedetomidine. So recommendation number 4 out of 4 from the ASA is surprising to me, maybe not surprising to everyone, but that they actually suggest dexmedetomidine to reduce the risk of postoperative delirium, noting that, of course, the hemodynamic impact of using this medication is a very critical component of your decision making. They had a large body of evidence that looked at uh, uh, dexmedetomidine compared with other medications or placebo, and it was universally a pretty I would say from their side, the literature that the ASA reviewed, it was a strong evidence across most surgeries and patients that Precedex actually does reduce delirium by approximately 40%. Again, the key thing here being that the hemodynamic effects are much more important, or should be weighed very, very heavily if you're deciding to use dexmedetomidine. This is just a subgroup analysis that they did, showing that like there was regional variation in by country. Not sure what that was. They noted that they did not look at specifically the dosage or the timing of administration, whether it was only intraoperatively or postoperatively or both. But it is worth noting that there was large heterogeneity in cardiac surgeries and oral maxillofacial, whereas most other surgeries, it was more of a clear benefit. So the heterogeneity was high in this literature review. However, I think it was still a recommendation from the ASA. They did note that the effect of dexmedetomidine diminished with decreasing baseline risk. So a higher risk patient is going to benefit more from dexmedetomidine from their literature review. They did say there was a possible publication bias, but they did an analysis that suggested that the severity of publication bias would be so high that it was not possible, that the effect is real of dexmedetomidine in their view. And again, just to point out there, the magnitude of the effect was actually pretty similar across all surgeries except for cardiac and some mixed procedures, oral maxillofacial surgeries. So just to, I guess, say again that the impact of dexmedetomidine was pretty consistent across surgery types, except for cardiac and oral maxillofacial surgeries. And this is just a table where that is pointed out in terms of the heterogeneity of the studies for the cardiac cardiac surgeries. There wasn't a statistically significant impact of dexmedetomidine for cardiac surgeries. And so in contrast to the ASA, the Europeans stated that they did not suggest the use of any drug as a prophylactic measure. This recommendation is weak with low quality of evidence, which is basically because of the heterogeneity. And so they actually follow up this recommendation saying that they know that some people will be wanting to use dexmedetomidine intraoperatively or postoperatively with the aim of preventing postoperative delirium. And so they just strongly recommend to really consider the hemodynamic effects of this medication. And so they have a good note here. They say that their rationale for not suggesting dexmedetomidine, despite the literature showing that it has a good benefit in most surgeries, was just because of the principle of first do no harm, and that the specific dosage and timing of dexmedetomidine is yet to be well defined. And so just I think it's worth pointing out maybe quickly One of the studies that they looked at in the cardiac surgeries, that was an extremely well done and large multi-center trial. It was called the Decade Trial. This is highlighted here on the slide. It actually showed a non-significant increase in the rate of delirium with dexmedetomidine. And it like just stood out to me on their forest plots that it like, what is going on? Why is this cardiac trial so different from everyone else? And maybe somebody in the audience will be able to point out that there's something very obvious going on, but there's been follow-up publications looking at the interaction of hypotension with dexmedetomidine possibly causing the increased rate of delirium with dexmedetomidine in these cardiac surgeries, and they showed no relationship. So it's kind of a mystery. And so this is this really unique and I guess going against the grain with the rest of the evidence, this study looking at dexmedetomidine to prevent postoperative delirium. They also had a primary outcome looking at atrial fibrillation. And this was all in cardiac surgeries across multiple centers, published in Lancet in 2020, and it was a randomized controlled trial. It was a very strong study. They found no benefit of dexmedetomidine for either atrial fibrillation or postoperative delirium. And like I said, it actually showed an increase in the rate of delirium with dexmedetomidine. So I just wanted to point out their protocol for dexmedetomidine. This might have been part of the reason why it stood out, is that they had a 24-hour period of infusion starting intraoperatively pre-bypass at a rate of 0.1 mics per kilogram per hour. It then ramped up to 0.2 mics per kilogram per hour. And then after the patient went off bypass, the rate went to 0.4 mics per kilogram per hour, which was maintained until 24 hours. They analyzed with intention to treat, and they did a long postoperative delirium detection measurement, so all the way to post-op day 5, which is probably on the longer side. So it was a very well done study, and it was a large study. It was 800 patients. And I said it was a non-significant increase in the rate of delirium, but it was pretty close. It was when they used a very tight confidence interval, it was non-significant. But if they just did a basic 95% confidence interval, it was a statistically significant increase in the rate of delirium with patients undergoing cardiac surgery that got dexmedetomidine. There was no difference in the outcomes in terms of kidney or 90-day pain. Those were their two secondary outcomes. And so there was some questions about like hypotension that may have been the contributing factor here, but it's not clear. And in fact, a study that analyzed it said that hypotension was not a confounding factor in this study. And so there's possibility that some discussion around this is it possible that the benefits that are seen with dexmedetomidine are specifically are some of the studies looking at protocols that are using it more just post-operatively or for specifically helping with sleep. And so that was one of the questions raised, that maybe the reason why this Decade trial that looked at a continuous 24 hours of infusion showed an increased rate of delirium was just because it didn't have the same type of impact on sleep. It wasn't focusing and helping the sleep like other studies are. So the second of the three medications we're going to look at is ketamine. So the ASA had a look at the evidence and they said, no, it doesn't have any impact on delirium, whether good or bad. There's just no difference with ketamine. But we will quickly discuss the possibility that the studies just have not looked at it in terms of the dosage differences. So With the ASA, they looked at quite a few studies, 20, and they had large heterogeneity in the dosages, so 0.25 to 1 milligram per kilogram. And the timing of administration differed. So that resulted in just a huge amount of heterogeneity, which made it really just not a good meta-analysis. And so that's from the ASA. And on this slide, if it's easily seen by the audience, I'd say that there's just this study, Avidan, that just like showed, okay, it's not quite the same as the other studies. It's more of a almost like worse impact of ketamine, and there might be a reason for that. It I'll talk about the study in a couple slides, but just first to just reiterate, the ASA said that there's too much heterogeneity in the studies looking at ketamine. And so they actually only had one study because of how strict their inclusion criteria was. Sorry, this is the EJA. They only looked at one study with ketamine because their criteria was more strict. And the dosages were actually much higher than what some other studies are suggesting that benefit of ketamine might be is lower than 0.5 milligrams per kilogram. So the EJA said the same thing. There's no difference in delirium rates with ketamine. The recommendation was weak in terms of not recommending any prophylactic drug, and the quality of evidence was low. And so I'll just point out that there's recent literature that's been published since the two articles we're discussing today that have a large amount of patients looked at and a scoping review to look at like what's going on with ketamine. Is it possible that it's just the difference in dosage and timing of administration that's causing like a dilutional effect? And so when they did the scoping review and this study published in the British Journal of Anesthesia very recently, a few months ago, they found that 40% of the studies found reported decreased incidence of postoperative delirium with ketamine. And then they looked at what's the measurement period after surgery. And it's actually most of them were looking at only 48 hours after surgery when the psychomimetic effects like hallucinations are the greatest. And so it was clear to them in this paper that the studies that looked at shorter durations were less likely to report a benefit of ketamine. And there's actually been another study that was applying a bunch of math to it was a retrospective study by Kaiser et al. Analyzing 100,000 patients, and they found an optimal dosing of ketamine to be between 0.25 to 0.34 milligrams per kilogram intraoperatively that may reduce the incidence of postoperative delirium. And so this was published in Anesthesia, and they divided the cohort into low dose and high dose. 0.35 was the cutoff, and they found that the odds ratio of the low dose ketamine actually was 0.67 for ketamine in reducing delirium rates. They adjusted it using a bunch of confounders and still found that the adjusted odds ratio was 0.73. And it's a significant impact with ketamine on the low dose side. And this graph just shows that the pink line is 95% confidence interval, and it just shows the dosing, optimal dosing at 0.25 to 0.34, having the greatest impact. And then it doesn't have much of a like sharp cut increase in the rates as you go beyond that. It's just almost a linear curve going beyond 0.4 and in increasing the delirium rates compared to no ketamine. And so this trial that I pointed out that was included in the meta-analysis of the EJA that had a higher rate of delirium, they actually did not, they only had as the lowest ketamine dose was 0.5 milligrams per kilogram. And they did note that there was a trend when they compared 0.5 to 1, that 0.5 had a non-significant increase. It was compared to 1 milligram per kilogram, that 0.5 did not have increased rates of delirium, but still had hallucinations and nightmares, whereas the 1 milligram per kilogram did have increased rates of delirium. And so they didn't explore smaller dosages below 0.5, which is, I think, a key element here of the ketamine story. And then just a quick break between the second and third medications we're going to talk about. Intraoperative EEG monitoring, everybody's favorite subject 10 years ago. I'm not sure if it's a hot topic now, but it is included in the EJA's recommendations. So it's actually quite interesting. There's been these new recent Engages trials, which were very well designed. There was one published in 2019 and one published in 2024. The second one was looking at cardiac surgeries in Canada, over 20 sites, and good randomized control trials. And the second follow-up study in Canada was hoping to find a difference in terms of EEG monitoring, lowering the rates of delirium, and it did not, nor did the earlier study. And I think that was surprising to a lot of people. And so why the EJA recommends index-based EEG monitoring in their paper. The strength of the recommendation is weak. And they write in the paper say there's no significant benefit of process EEG by their meta-analysis. And then they go on to say, we actually upgrade the recommendation so that it's actually what's really helpful with intraoperative EEG monitoring is multi-parameter EEG monitoring that is not using the proprietary index-based number. It is looking at the density spectral array and burst suppression and raw EEG. And so they go into a little bit of detail about how vulnerable patients with neurodegeneration are very hard to monitor. They have low EEG power, and thus the index-based EEG is just not good. They have a lower rate of alpha band power frequency or alpha frequency power compared to younger patients, and that has an effect on the index-based EEG. And they did say that this strength of the recommendation was weak, but it was much more explainable than their other recommendation, which was to use index-based EEG as well. And so overall, they did look at burst suppression, and they found it had a relationship with postoperative delirium, which I don't think is surprising to anyone. And then raw EEG, there's not a lot of studies on it. It's hard to include in a study, but that they hypothesized in the paper that a lower preoperative spectral edge frequency is associated with postoperative delirium. They stated also that the absence of slowing in EEG when the patient is being induced is a predictor of delirium. And then they said that just overall lower EEG power in both awake and unconscious states has a relationship with high rate of delirium. And that also the lower alpha band power in patients has a bit of a relationship with postoperative delirium. So the summary on intraop EEG monitoring from the EJA is use multi-parameter DSA and raw EEG, and that is superior to the index-based BIS or PSI monitoring. They really strongly suggest having training for the raw EEG and density spectral array. They do suggest to really look at burst suppression. And then finally, they also suggest to adjust the sensitivity scale for the alpha band power, if that is possible on your DSA screen. Because making that more visible can avoid over anesthetizing your patient. Last section of the intraoperative section here is short-acting benzodiazepines. So ASA looked at 4 randomized control and did not find a difference in terms of short-acting benzos versus placebo in terms of the rates of delirium, nor did the EJA. To, I guess, put more emphasis on this, we have our benzodiazepine-free cardiac anesthesia for reduction of postoperative delirium, randomized controlled trial, which doctors Peter Hedlund and Ryan Picklick were involved in, which was a very well-designed study in over 19,000 patients using a restrictive versus a liberal midazolam policy. So restrictive was no benzodiazepines, and then liberal was at least 0.03 milligrams per kilogram of midazolam, and the mean dose in the study was 4.1 milligrams. And then they looked at delirium for 72 hours after surgery. They found no difference in the rates of delirium with the intention to treat analysis. So the rate of delirium with the restrictive arm of the study was 14%, whereas the liberal arm was 14.9%. It's worth noting that there was an interaction in terms of if a patient in the restrictive arm was exposed to benzodiazepines in 24 hours prior to surgery, that had an effect on the results. I guess, not to get into too much into the weeds, the end result was there's no difference in short-acting administration of short-acting midazolam in the rates of delirium, and we can be just even more confident that administration of short-acting benzodiazepines is a something that shouldn't take up a lot of our cognitive space when there's a highly anxious patient coming into the OR, that we can administer it without a lot of concern for postoperative delirium. There was a difference in terms of if they analyzed it in terms of going into the per protocol analysis. There was a significant difference in delirium rates, but the number needed to treat was 91. So you need to restrict benzodiazepines in 91 older patients to benefit to prevent delirium in 1, and that's just in one type of analysis. But the end result of the story was that there was no difference, because the per protocol analysis, I think, is considered to be an inferior type of analysis. That's enough statistics. I tend to get almost distracted with statistics here, because I'm looking at this graph and looking at 1 decade of life when they did a subgroup analysis in 70 to 80, and it did show like a trend here. It wasn't considered to be a significant interaction, but that the 70 to 80-year-olds had this like pull over to where the restrictive policy, meaning no midazolam, was favored. And it made me think that maybe there is a subset of patients, that are, they're not a high risk of postoperative delirium, they're not a low risk, they're kind of a medium level risk, and it just needs like there's a smaller tipping point, and that maybe just midazolam may have a little bit of an impact in a very small number of patients. Again, the bottom line is that it's such a small impact. It's a number needed to treat at 91 in the worst case scenario. So the postoperative period here, we're going to talk just about a couple medications briefly. Non-pharmacologic measures are stressed as being the first line treatment for postoperative delirium by the European Society of Anesthesiologists, and that medications are only to be used in severe and intractable distress. They do want to remind practitioners that hallucinations can occur in patients even when they're oriented, and that can be distressing. And so when there's severe and intractable distress, they do recommend haloperidol or atypical neuroleptics. It's just that haloperidol is the most well studied, and so they could recommend specifically haloperidol versus quetiapine, risperidone, and olanzapine, being the other agents that they said had indicators that they are just as efficacious and they have a little bit of a higher safety profile. But in terms of recommendation, haloperidol dosing was recommended actually smaller than what I'm used to. So 0.125 to 0.25, starting low and then increasing. And then they note that the maximum daily dose is 3 milligrams because there's a mortality increase when you go beyond 6 milligrams. This is mostly for ICU practitioners because we're not going that high, but I think it's still worth mentioning here. So the recommendation was to suggest a low dose haloperidol when non-pharmacologic measures fail, when there's severe symptoms, noting that there is side effects that you need to keep in mind, not just QT prolongation, but the sedating effects as well as the extrapyramidal symptoms and hypotension are side effects that should be monitored. And just to point out again that their survey of the literature showed that haloperidol was comparable with atypical neuroleptics, namely risperidone, quetiapine, and olanzapine. And then again, they just really emphasize that non-pharmacologic methods are first line, and haloperidol is to be only when those fail. And it is also worth mentioning that the use of antipsychotics has no benefit on delirium outcomes. It's just a symptomatic treatment. There's no effect on changing the delirium severity or duration, mortality, hospital or ICU length of stay. One of their last recommendations was do not use benzodiazepines for treatment of postoperative delirium unless the patient is having alcohol withdrawal. Both of those recommendations were considered weak recommendations. And then, interestingly, unlike the prevention of postoperative delirium, they actually have a recommendation of using dexmedetomidine for the treatment of postoperative delirium in cardiac surgery. It was also a weak recommendation. They said they may have given a recommendation for non-cardiac surgery. It's just that 7 of the 8 studies that they looked at were in cardiac surgeries. And so there was very high heterogeneity again in this analysis, but they still gave the recommendation for using dexmedetomidine for treating postoperative delirium in cardiac patients. So my summary is that overall, preoperative screening and multidisciplinary and multi-component delirium prevention bundles focusing on nutrition, cognition, polypharmacy, frailty, baseline function prior to hospital, and then orientation methods are all superior to any pharmacologic strategy in reducing the rate of post-operative delirium. In terms of pharmacologic strategies, the current evidence is actually by the ASA Task Force Advisory. It's strong evidence that dexmedetomidine overall in older patients does prevent, has a role in preventing delirium, but because of the hemodynamic effects, this was not a recommendation in the EJA article, but it was a recommendation in the ASA article. Again, the hemodynamic effect of the medication has to be taken into account. And then the last summary item here, for me, my take home was that from the European Society of Anesthesiologists, at least from their opinion, that intraoperative EEG monitoring is useful in reducing the rate of delirium when an anesthesiologist has training in identifying the density spectral array features that are showing that the patient is very deeply anesthetized. And so that was a recommendation by the European Journal of Anesthesia, was use intraop EEG monitoring, but specifically use the DSA and the raw EEG and look out for burst suppression.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.